Good morning, everybody. We were sort of going back and forth, who's going to be the moderator? So probably I think your sheet shows that moderator is Dr. Lakshmi. So we just switched our roles. Let me just start with a message saying that in 2005, there is a new policy came. A small tweak in terms of improving the institutional delivery. You know, the last 20 years, I think we have just done a fantastic job. So policies do make a difference. So that's the background. And you're all working on cutting edge technologies in the new age interventions. And we're trying to see how policies and regulations can help. So the way in which we looked at is saying that we always look for a policy to enable our innovation. Can we just flip it? If there is a policy and successfully implemented, what is that we can learn from there so that when there is a policy which is going to enable our innovation, how can we ride on it? To start that, I will request Dr. Hegde. So he had been in a few of the initiatives like eSanjeevani and others, where there is a policy in place, regulations in place, and the government support is in place, and what it means for the innovators and what we can learn from there. So let's move on. Okay, Dr. Hegde. So Dr. Hegde is from currently with the Gates Foundation, and he comes with tons of experience in public health policy. Yeah, go ahead.
Thank you, Mr. Vijay. Pleasure to be here. Wonderful energy, a lot of entrepreneurs, people who are solving wonderful problems. We had wonderful speakers just before us. I think it was a great start to the sessions, and I'm looking forward to the day. I think what Dr. Vijay touched upon, the eSanjeevani experience, all of you must have observed what happened post-COVID and how the entire telemedicine and teleconsultation ecosystem kind of changed because of the COVID pandemic, probably one of the few good things that came out of the pandemic. So I think the lesson for all of us is to identify and pivot ourselves to what is the current need of the hour. I think Dr. Patil spoke about earlier about the issue of access and equity and so on and so forth. But I think that one key aspect is the problem statement. And I think that's very critical. So how do you really align your problem statement to the global, national, and local goals? I think is very critical. So the first thing that that all of these advancements in technology are kind of teaching us is to figuring out how do you align your organization, your business models to the goals that have been set up already, and find the alignment there. I think that's very critical from the perspective of whatever organization that you are wanting to build. The second one is, who are the stakeholders, right? The government is a big stakeholder. There are private organizations also, but in India today as well, the biggest service provider is still the government when you put together primary, secondary, and tertiary levels of ecosystem. And people do access primary, secondary service providers. And so government alignment is very critical. What are the government priorities? What are the ways in which our solutions are aligned to the priorities that the government sets? I think is very critical. So understanding the stakeholder is also very important. At the same time, there is a requirement for funding. Capital is very important for all the innovations that people do. So identifying the strategy of the funders, which is in most cases aligned to the government and the national priorities, I think makes it that much more easier for innovators to also get involved in it. And the third piece is with respect to the due diligence that the organizations need to do with respect to what are the key policies and regulations that are available. So I think Dr. Vijay did mention about the policy of the home deliveries. How do we move it to hospitals? That was the policy that came in 2005. What is really critical is for us to understand, for all the innovators to really understand whether what we're working on is really going to see the light of the day and can be scaled up, right? Are there policies that are conducive to the work that is being done? Like, for example, many of the governments still don't have procurement policies for software applications, right? There are a few which are coming up, but there are different ways and mechanisms to do it, but it is still a challenge. So understanding that policy ecosystem within which you frame the innovation, I think, is very critical. So some of these have been our examples and some of these are the lessons, but happy to speak more, Vijay.
So I think what he said is align with the policy. Okay, and I think all of us, we look at as innovators saying, align with the current workflow. Don't try to break the workflow. Align and then slowly modify the workflow. I think broadly that is what he was mentioning. The next touch that we looked at saying that, okay, why don't we look at one of the current policies being rolled out, ABDM. And all the new age technologies what you are working on, we believe that ABDM can be a great enabler. Let me ask Sushil to talk about what is ABDM and what is it in for innovators in the current context of new age technology or interventions, what we are looking at it. Dr. Sushil.
Thank you, Vijay. And I am happy to sit amongst a good set of panelists here. And it's very happy to see all of the innovators get together. And also was great listening to our previous speakers who were emphasizing on the fact of democratizing healthcare selection and giving the power to the patient, right? I mean, it sounds really great that we all want to do it, but sometimes, there are these small blocks that are always missing. And that is where ABDM tries to solve a partial set of problems or maybe the entire problem. Because the key to ABDM, or I would say the crux of ABDM, is about empowering the patient with being the owner of his or her own health data, right? So how does it work? I will give you a gist. I don't know, most of you would be aware of how ABDM works or may not be aware. So we have some registries. We have a registry for patients, we have a registry for professionals, we have a registry for facilities, and we have some data exchange protocols. We have a consent manager and we have a claims exchange protocol, which is maintained by the National Health Authority at Government of India level. And based on these common single sources of truth, what now happens is whenever a patient visits a hospital which is using an ABDM compliant system, now ABDM compliance is again achieved by any tech company which undergoes through this sandbox process. So there is a set of APIs which are openly available. You can integrate with them and get access to these registries and protocols. And once you are done and the patient visits to a hospital which is using this ABDM compliant system, the patient gets the health record linked to the ABHA. ABHA is the Ayushman Bharat health account, which is the common unique ID for each patient. Now this is based on Aadhaar basically. Of course, many questions have been asked, why do you need ABHA when there is already Aadhaar? And we all know that Aadhaar Act doesn't really allow us to use it at our whims and fancies. So to make sure that we are aligned with the act of Aadhaar, we have said that we'll create ABHA, which will be over Aadhaar in line with the India architecture. So based on that, now what happens is the patient gets a health record linked to the ABHA, and this record gets pushed to something called as a personal health records application. Now this personal health record application is basically the powerful tool that the patient will get. It is something like a UPI app that we use. We have so many UPI apps. Some like to use PhonePe, some like to use Google Pay, some like to use Bheem. But it's all left to the person who uses it. So in the same way, we have more than 16 PHR apps now, which are certified by National Health Authority. They also go through the same process of sandbox. And once this health record gets pushed to this PHR app, the patient can now give consent to share with any other professional or provider, and the professional will have access to all the previous health history, provided it's all there in the PHR app, and can take better decisions. And the patient can always select the time of visibility, the type of records that he wants to show, and all such things. So this is the basic framework of what ABDM is here to offer, and how it is trying to democratize the whole, healthcare decision by the patient. One particular use case which I would like to highlight is when I go to a diagnostic center, let's say. I go to a diagnostic center, and this diagnostic center takes a X-ray of mine, and then it says, I will give you a printout, or maybe give me a CD, which is again openable on a DICOM viewer, let's say, or maybe send an email to me. Now it's all scattered here and there, everywhere. Some may have a CD player, some may not have a CD player. What do I do with this image, really? We have, low digital footprint DICOM viewers now, but maybe not all these diagnostic centers have it. But with ABDM, if the system is compliant to ABDM, it can send this record directly to your PHR app, and it just becomes a file. And this file can be shared with any provider that you visit, and you know where it is. You don't have to go search in your Almira and say, oh, where is my X-ray, where is my mammogram, or whatever it is. So this is quite a powerful, digital public infrastructure that the government has set in. And Karnataka has set up a Karnataka Digital Health Society, which is headed by Shri Vipin Singh. He is an Indian Forest Service officer with enormous experience in e-governance in Karnataka. And the problem that Dr. Hegde was trying to highlight regarding the policies of procurement is all probably left to a very good decision-making capacity, because it's all there. The Karnataka Transparency of Procurement Policy, the KTPP Act, defines it all. But ultimately it lies as to who decides, right? If the decision maker knows how a software procurement really works, it goes through. If the decision maker doesn't know, then it doesn't go through. So we need to identify the right people at the right positions, and now we are lucky in Karnataka that we have an experienced officer, and we are seeing many procurements happening in the health department as well. So this society is here to basically oversee the entire procurements of digital health, and also implement some of them with the help of the Department of Health and Family Welfare. So I hope that more and more tech companies will adopt to this ABDM, where your data is packaged in the right manner to flow into a PHR app, and then flow to another provider with the consent of the patient, which will basically, make the patient finally a very empowered person. I am hopeful that all of you align with this idea and you see value in this.
Yeah, thanks, Sushil.
Thank you.
I think when I spoke to Sushil a few days back and following the ABDM, I think there's a lot of opportunities for medtech innovators to exploit it. But everything has been spelled out? I don't think so. But can I be the pioneer in using it, exploit it to scale my solution? Probably there is something hidden in that. The key word is personal health record. After all of us actually trying to serve the patient, whether we can be adding value to the personal health record, which can be used by the patient to become better. Especially the new age technology, what you people are trying to do, it makes a lot of sense. So please explore that. I know it's a little disjoint, but we are trying within 30 minutes what best we can provide. Now let me move on to Dr. Lakshmi. She comes with tons of experience of working with the innovators in the innovation ecosystem. So can I ask you to say, what are the one or two policy changes you think is required, or policy changes should be adopted by the innovators for scaling their technologies?
think last 15 years, the definition of health and innovation has phenomenally grown. I think personally for me, initially when we started looking at startups in the healthcare space, we had people who are building point of care, diagnostics, health and technology both have evolved. Now today, I mean, even you take this conclave, for example, we are talking about wellness, fitness. So the definition of health has gone beyond traditional health. We are looking at fitness, then maybe safety, sports, pharma. I mean, it's become wide. Technology, on the other hand, where we're talking about maybe looking at devices about 20 years back, now we're talking about AI, IoT, data. Both have grown parallelly. That's one part, right? Second thing is, I mean, if you look at the entrepreneurs, I think the doctor from Spurge was bang on, no? Many of them build a solution, they build a hammer, then go searching for the nail. So even their policy would maybe come into picture, right? How can we enable the ecosystem to co-create solutions? Health especially, we are not talking about something very abstract. We are talking about saving lives, which is critical for everybody, right? So personalization is the need. You cannot build something and adapt it to another situation. So when you're talking about situation like this, co-creation is very, very important. So how can there be policies? I think very recently, a medical council came out with a policy where they're now enabling doctors to become entrepreneurs. ICMR came out with a guideline, I think about 4 or 5 years back. They said that doctors, while they are practicing, teaching, whatever, can also become entrepreneurs, can also work with incubators. So what are the policies which we can bring in to make this happen on the ground? So I'm being very frank, see, policies are there everywhere. But on the ground, reality is different. You can ask any of the healthcare entrepreneurs here, healthcare looks very jazzy, very nice from Mount Everest. When you're on the ground, things are really different, right? So it's very important to co-create solutions. See, one of the reasons when I was talking to AVR, I said, you should moderate because he's seen the healthcare ecosystem 360 degrees. He used to work in a corporate healthcare setting. He's been an entrepreneur, works with innovators, works on the policy junction, so understands every bit of it, right? So it's not very easy to be an entrepreneur. It's not at all easy to be a healthcare entrepreneur. So policy is very, very important. And as Dr. Hegde said, so how do we make sure that, see, he brought in a very valid point saying, when there are startups building solutions, you should see whether what you are building, how does it fit into the existing policy framework, right? How do we sensitize entrepreneurs on this aspect? You're building something, but where is it going to be deployed? Is it going to be deployed? Can it scale up? I think that's very, very important. Point number one. Point number two, what is it that makes healthcare very difficult? One is definitely the regulatory. Other one is a long gestation time, right? So how can we bring in policies to make sure that this longer gestation is cut short? See, if gestation is because of the research, because of regulatory, fine. But many of the entrepreneurs, the longer gestation is also because of the inability to scale, because of the ecosystem which is there. See, most of the entrepreneurs, when they present their, I think the TAM, SOM, whatever they present, right? They say this is a huge market, we are building it for India, India-centric solution, especially when they are trying to raise government grants, government funding, right? Nice to paint a good picture of India, bottom of the pyramid and all that. But how do we enable them to tap that market? What are the policies required? How can we make the public health system become more friendly for the entrepreneurs? I think that's very, very key.
Thanks, Lakshmi. So she talked about the tougher side of being a medtech entrepreneur. But I'll just give you the other perspective. This is what I'll tell people. See, we all talk about neonatal mortality, correct? It's a statistics for many people. For that parent, that one child, alive or dead. And we make the difference as a medtech entrepreneur. So it is difficult, but you are in a job which is going to be really changing the landscape of the. I just wanted to add a few more things on the regulatory side. How many of you heard about this terminology, digital therapeutics? Yeah, few people. So the most of the topics of what will be theme of this conferences comes under digital therapeutics. So currently MDR 2017, what we have for us regulatory framework in India probably is not meeting the requirement. So we need a regulatory pathway which enables this digital therapeutics. At the end of the day, what you are all trying to do in this domain, this intervention, looks more like a therapy. So we need a regulatory for therapy, not for devices. I think that's what should be evolving. So that should be the way we should be moving around, which means saying that I will have a base level of regulatory, and then I will do a post-market surveillance to improve my product. Because I will not be in a position to provide all the data in day one, because that is how most of this technology is being used. So on the regulatory side, look for digital therapeutics. There are Japan, Germany, and Korea, even US, they have a regulatory pathway. Adopt the regulatory pathway, even though it is not mandated in India. It creates trust and also makes your life easier to adhere to the safety standards of delivering care. So what we thought was, can we have one or two questions before we go to the round two? Yeah, so digital therapeutics actually is, let me try to articulate that. It's actually personal driven, data driven, and incrementally provided services. Okay, so you come with a diabetics, I assess you, I give you a treatment, I do a monitoring, and keep modifying it. So that's in a very broad sense. And that's why I said continuously monitored. I cannot guarantee this therapy will work. Okay, I'll have a base level of regulation done, and then subsequently I keep doing a market feedback. Yeah.
Thank you. Thank you, sir, for bringing up the topic of regulation on digital therapeutics. In fact, from an insurance standpoint, we get to engage with so many health techs promising therapeutic intervention, but I think the point that you mentioned, sir, on the need for a framework for clinical certification and safety standards, very critical, because at times we see many of these therapeutic startups come with founders from a commerce or non-medical background as well, right? So it may potentially end up doing more harm than good, and I think this particular topic should be pushed with a little more urgency.
Sure. Thanks for the input. Because from the government side to come with a policy or a regulatory framework may take some time. But I believe that as an entrepreneur, we owe to the patient a safe intervention. So my recommendation will be, don't wait for government to come with a policy. There are global policies are available, try to adopt it. And there is a general feeling saying that adopting regulatory pathway is expensive. Please take it from me, it is not. It is actually an enabler and is your friend to make innovation reach the last mile safely. Okay. I can take one more question if it is.
Yeah. So firstly, good morning to everybody and also the fellow founders here. So this question is for Dr. Sushil. So you have mentioned about ABDM. So and you have compared like with Aadhaar. So considering privacy issues, right to privacy, so article number 21. So we had seen like previous issues of using data in a different way altogether. Now we are actually keeping very, very critical data of health on online. How exactly government is actually going to do it to make sure about the safety concerns? And the major part about India is that we have got tier 3 and tier 4 cities or tier 4 rural areas, like where the tech penetration is not that great. And we are talking about considered Karnataka itself, like where we have in the North Karnataka, where we have good number of districts, like where the tech penetration is very, very low. How exactly the Karnataka government is going to do that?
So, what I would like to say is, one is, of course, government always has a challenge to see how solutions work at scale. And scale in India or Karnataka means diverse. You know, it is always diverse. North Karnataka is probably less connected. Southern part of Karnataka has more density of, accessible facilities and all such things. So we are also trying a diverse set of solutions. We don't feel that one size fits all. We are trying out solutions which would fit for larger hospitals. We are trying out solutions which will fit for our PHCs and sub-centers differently. We are also trying out solutions which will fit to the community part of service delivery. Because we realize that it is not something that, you call for a large tender and then some fellow comes and takes, I will digitize right from the district level hospital of Bangalore till the smallest sub-center in North Karnataka. It is not going to work out. We have understood it and we have tried to, break this whole problem into chunks, right? So the community part of it has been handed over to some person. The PHC and sub-centers are being handled by some other person. The facilities above these, which are considered more or less similar, are being handled by some other person, because we feel we need to have that flexibility and that tailored approach to see that a solution is actually getting implemented. And to your first part of the question, where you ask about data privacy, one thing about ABDM is ABDM follows something called as a federated architecture, right? So by the term federated architecture, we don't create any central data repository of health under ABDM. The data stays where it was created. It could be an on-premise server, it could be a cloud, wherever it was created and stored. Only a copy of the data will be sent to the PHR app of the patient, which becomes completely the property of the patient now. So the earlier narrative that hospital owns the patient's data. I mean, if it goes into an HIS of a hospital, hardly the patient knows what has gone in, what is not gone in. Sometimes some of the records may not be shared with the patient also, and there may be quoting of various other policies from the hospital level and all that. So, but now everything that is linked to the ABA comes directly to the patient. He doesn't have to go and fight for it again or ask for it again. This is one part, that we have a federated architecture and we're not building a central data repository in any form, which actually increases vulnerabilities, as you have rightly pointed out. The second part is regarding the data privacy of as far as the regulations are concerned. So I think most of you are aware of this new act that has come on, the Digital Personal Data Protection Act, right? We are all quite hopeful that the rules will be very soon coming out. The draft rules were out at some time, and I feel that they are quite strong in terms of giving rights to the patients. Again, there is a question to it whether the patient really knows what is data privacy, what is the literacy around it, but these things will only get solved as the digital literacy increases and improves, and I don't think there is an easy solution to it. What I believe is we have a framework now, and we have a framework for regulation from the Digital Personal Data Protection Act. A partial bit of it is also handled by the Health Data Management Policy by the NHA, which is tested for conformity during the sandbox testing of any application, and the federated architecture are three basic pinpointed answers to your question. So the rest of the things, I think it will evolve as our literacy increases and everything increases, and we'll see how it pans out. Yeah.
Sure,
Yeah,
thank you.
the key word is evolve. Okay, I think all of us should have a lot of patience when the new rules comes, new policy comes, and now gets implemented. I think technology is moving probably faster than some of the regulatory requirement and privacy requirement. So I think again, I'm repeating the same thing. We owe all these things to the patient. So we need to get the best from the global best practices and use it. Yeah, just give it to you, because I want to listen to Dr. Hegde about Gates Foundation as an enabler. Just go ahead.
Recent times. So, what I understand is post-COVID, there was a big boom of things, and initially there are companies who had got into this field and burnt their fingers, and now it is blending into the background. And what we most of the times we do is digital therapeutics. Most of the times it is almost into the infrastructure level now. It is. So now, for my question is that what I observe is the US market. There are so many regulations being implemented every other day. There are pushbacks from the traditional doctors, because the DTX has taking data from different sources like devices and other things, which is not validated in the current pathways, which we have established already. Now, like country like India, where it is evolving, and our regulations are yet to catch up with these regulations, which is happening in US, Germany, France, and any other European countries, and Japan also. Now, with our little digital literacy, and one question is how fast can our regulations catch up with these global regulations? And second thing is, even if it catches up, are our patients are that educated in terms of their data literacy thing? And how is this going to be adopted in the near future? All these new technologies which we propose further. Yeah.
I wish I had all the answers. But thanks for pointing out. The first digital therapeutics company in the US actually went bankrupt. I think that's what he's trying to say. But I think what we are doing will fall into that category of digital therapeutics. And my personal belief is that we will all move from pharma therapeutics to the digital therapeutics sooner, especially in the context of two things. Preventive, the second one is disease management. Both requires a lot of data, both requires a personalized intervention, both requires a personalized analysis. Okay, and the digital therapeutics infrastructure will provide all of them. Okay, let me just ask a question to Dr. Hegde. Because another enabler in the whole process, I think he was leading to funding. And so let's listen to him how organizations like Gates Foundation enables innovation, especially in the public health.
Sure, thank you. Yeah, so the Gates Foundation is a not-for-profit funding agency. We work across multiple countries and multiple states in India. Our core area of work has been reproductive, maternal, newborn child health, nutrition, and infectious disease cluster, especially in India. Obviously, in the past, we did a lot of work on HIV. We did quite a bit of work on HIV in India in particular, and several countries in Africa as well. But over the last decade and a half, we've really pivoted to reproductive, maternal, newborn child health and infectious diseases, because we feel that we are able to, if we are able to address those two large clusters, then we'll be able to solve and contribute something meaningful globally. Within this context of RMNCHN and infectious disease, one of the key enablers that we've always found is digital technology, products, and practices. I think broadly you can use permutations and combinations of digital technology whichever way possible, but I think products and innovations have always been at the forefront at the Gates Foundation. We believe that investment in products, practices, new practices, innovations have the power to change the trajectory through which we are able to address reproductive, maternal, newborn child health and infectious disease challenges. One of the ways in which we do this is also to bring up problem statements. We've had some wonderful discussions today about problem statements. I think very critical to curate, dissect out, and really get into the details of problem statements, which we are able to support through research, through evidence generation, through our partnerships with a large number of organizations across the globe, and in the country as well. And the second way is we provide catalytic support. We are working with partners, a large number of organizations. In fact, we do work with Inaxel as well. And the idea is to really help organizations who are finding solutions to problems in ways that will generate enough evidence for governments to then take it up. Our role has always been catalytic and supportive. Our role is to help and support innovations, innovators, to really identify problems, identify solutions, work on the solutions, generate evidence, generate data, help shape policies, and then go back to the government and say, look, this is something that is worthwhile, can be done. And government, being such a big player in this entire ecosystem, has the potential and the capacity, which they are currently doing a lot, to take these problem solutions to scale. And that has been traditionally our role.
Sure. Thanks. Okay. In fact, I really wanted to ask Dr. Lakshmi, but I'm also advisor to their innovation center. I can also speak on behalf of her. I think all the innovators, you can reach out to Dr. Lakshmi for incubation support. And through that incubation support, I can be available for some of any of the regulatory related requirement. And reach out to Sushil for any of the ABDM related requirement. And thanks for being such a wonderful audience. And hopefully we met that timeline. And hopefully we were all useful to you for the time you have spent with us. Thanks a lot.